the causes of their COPD are, what its risk factors are, how to use inhalers, or given information on smoking cessation. You're basically told, well, I think you have COPD, here's your inhaler, see you in a couple months. That's kind of the education that they're getting. Study subjects felt physicians were primarily responsible for assessing proper technique and training of inhalers. Just gonna let that one sink in a little bit. If patients think physicians are primarily responsible for this, it's no wonder why it's a problem. And I'll tell you, only a small minority of pulmonologists report being very knowledgeable in teaching patients how to use, clean, maintain inhalation devices. Those are pulmonologists. And less than 50% of pulmonologists report discussing device options with their patients or screen them for any physical impairment that would impact device delivery choice. Again, those are pulmonologists. If they're admitting that they don't know these things or don't do them, we can be pretty sure that primary care providers are not. So we also can make some conclusions. If education isn't given that very first time they've been seen, there's pretty good odds that it's not going to be given later on. You don't diagnose somebody with something the first time and not really talk about it, and then on their 3-month follow-up then go into, oh, you know why you have COPD? Here's what the symptoms are. That's not going to happen. So inhaler technique is obviously a huge priority. If prescribed a type of inhaler that a patient gets confused with, compliance definitely is affected. And Danette yesterday alluded to that with airway clearance devices. It's pretty much the exact same thing. COPD symptoms are largely managed by inhaled medications. So it's crucial patients are doing them correctly and adhere to the prescribed dose and frequency. And as this table shows, this is multiple different studies, and there's actually way more than that. Inhaler technique errors are widespread. So we know it's a big problem in understanding how to use them. And it's even challenging for us to keep up on all of them. It's a lot more difficult than you think. So this is why inhaler education needs to be a priority. We need to teach patients more frequently how to use these, but we need to keep up on it and learn these and keep our skills up on how to teach them. One of the things that we have heard a lot from our patients since we've started doing these education is about the expense. We have heard they can't afford them, so they try to take less to make that inhaler last longer, or they just won't fill a prescription at all. And often that isn't shared with physicians right away, so it creates a vicious cycle. We actually had one patient that Shanna had that said, oh, I'm not filling that prescription, that takes away from my meth money. At least he's honest about it, I guess. So the best inhalers for COPD patients are ones that they can afford, understand and agree with, and will use regularly. And this is GOLD guidelines. That's what the GOLD guidelines are. They're not saying do this type of med or recommending it. They're saying whatever it takes to get that patient to agree and do it correctly, that's the best one. So we cannot allow choices of inhalers to be dependent on physician preference or what's on hospital formulary. So if we want to improve that, we need to make sure these medications are appropriate for a patient. Drink. So what's our role? With the shift in focus on outcomes-based medicine, we kind of need to reevaluate our roles and recognize that there is increased need for our profession to be leaders in providing patient education to chronic pulmonary disease patients. The clinical expertise we have in the disease management of COPD and asthma, for instance, make us the ideal practitioners to lead that initiative. We need to take more initiative by going back to physicians and making recommendations and not just asking for an order. Explain why you're asking for an order. That way you're educating the physicians as well on what evidence-based practice is. For example, when we're treating a patient with COPD and we see PFTs are not documented, go back to the physician and ask for them to get PFTs and explain why. Say, you know, I see this patient is diagnosed with COPD, we're treating it. It's really important that if they haven't had PFTs, we should get them because maybe they don't have COPD, and we don't want that diagnosis following them when they leave. We need to talk more to patients about recommending, or talk to physicians to recommend patients more for pulmonary rehab, because it is estimated it only happens 25% of the time. We need to make sure inhalers patients are prescribed and appropriate. For example, not every COPD patient needs inhaled corticosteroids, yet we find tons of them on it. I don't know what's going on here. Gold guidelines are actually against prescribing patients routinely on inhaled corticosteroids. They believe it should only occur if patient symptoms are not under control using a long-acting muscarinic or long-acting beta agonist. So we need to be proactive in also getting these patients transitioned from scheduled short-acting bronchodilators to those long-acting inhalers during their hospitalization, and explain to the physicians why. It's the patient education. We need to make sure what they're going home on is going to work and that they know how to do them. So we should be educating patients every chance we have, and it's a mistake to assume our frequent flyers are just non-compliant. Some of it might be because they just don't know how to self-manage, and that's why they end up returning over and over. So our facility, like all major hospitals, are looking at ways to reduce length of stay and reduce our readmissions, as well as improve quality of care. So we came up with a COPD educator program, and it was developed as one way to help contribute to these goals. And in tackling like a project like this, we first really needed to dive into what our problems were to develop the objectives of what we wanted to accomplish. So we reviewed patient records that had been coded with a DRG of COPD exacerbation on inpatient admissions over a year's time. Of these patients, 30% did not have PFTs, nor were follow-up PFTs done after discharge that were at least documented in our EMR. Can't say if they had them outside our facility or not. Of the 73%, which is pretty good, that did have PFTs prior to admission, 13% had been interpreted as normal, and 4% were interpreted as restrictive. Yet they were still classified and being treated as COPD. So that kind of ties in with that study that this does happen frequently. 63% of our patients were treated with scheduled short-acting bronchodilators throughout their hospitalization, and that's no surprise to us that Q4 treatments for everybody until they are out the door. But they did not have any transition to long-acting inhalers, that same 63%. So obviously, evidence-based practice is to treat an exacerbation with your short-acting bronchodilators, and then transition to a LAMA or a LABA, which is long-acting muscarinics and long-acting beta agonists, as soon as possible to make sure that their symptoms are managed on those long-acting and that they get training on those inhalers. So this showed us that we had a problem with utilizing evidence-based medicine ourselves, and we recognized the inhalers we had on formulary were very limited. So it made it difficult to ensure patients were receiving inhalers that they actually had the ability to do effectively. We noticed pulmonary rehab referral was really lacking among this group, and the education that they had been receiving was more like generic discharge instructions. They weren't actual self-management skills type education. So improving these problems became our objectives. So we networked with other institutions to see what they had been doing, because a lot of places are scrambling at the last minute to try to put together programs. And we found out a lot of them have adopted standard COPD admission order sets, which we don't have. And they also have a lot of RT-driven bronchodilator protocols for COPD patients in particular. So these are all kinds of elements that they incorporated into their education program. So we next collaborated with Pulmonary on developing an education initiative that had both an outpatient and inpatient component. So we started with the outpatient component first, mainly because we had a lot of control over how that went about. And it makes sense. A lot of our chronic pulmonary patients are routinely seen in our diagnostics lab to get PFTs. And so our diagnostic therapists see these patients routinely, so it fit in that they could start doing more patient education. So while we always instruct patients on how to use an MDI as we're giving post-bronchodilator spirometry, just so we know they're getting those meds, we weren't really giving them additional education. As we know, a lot of patients take a variety of different inhalers, a lot of dry powder inhalers. So we began to ask patients more frequently about other inhalers that they take, and then start providing routine instructions on those. We created orders that physicians can actually just order inhaler training or PEP device training, and just general disease state education type training. We developed a specific note to document it, and this just basically outlines different topics that you could cover, and it helps create a script as well for the therapist so they know what to go over. And we've made several tweaks to this. Like initially when we started doing inhaler education, it was taking a lot of time for therapists to actually find what inhalers patients were taking at home. So we went back and worked with Epic, and they created it so any prescribed inhaler the patient is taking just automatically pulls in when we create that note. So it's actually broken down to like the SABAs, the SAMAs, the ICS. So that tells us more like, okay, they are on this, but here's the delivery device and how often they're taking it. So it's easier to work that into the education. We started routinely assessing a patient's ability to effectively use particular inhaler devices as well, and I'll go into that next. Additionally, we put inhaler education toolkits together. So basically, they're little kits that have a variety of different demo inhalers. So we can do that hands-on demonstration and have them do it, because a lot of times they don't bring in their own inhalers to their appointments. So I'm going to talk more about the ability to do a particular inhaler. So while we can teach proper technique, it is important to first know if a patient even has the ability to effectively generate enough inspiratory flow for a particular device. If you don't, the medication isn't going to be delivered effectively. They aren't going to feel it work, or that it's working, which probably isn't. And so they're just going to stop taking it, or take it and not be effective and wind up in the hospital. So knowing what a patient's peak inspiratory flow rate is important when selecting a type of inhaler. And peak inspiratory flow is routinely on pulmonary function tests, but the problem with using that is that pulmonary function devices have little to no resistance to them. So you're getting the very best that they can do with no resistance whatsoever, and inhalers actually have a lot of resistance. It is estimated 1 in 4 of every patient have less than 60 liters a minute of peak inspiratory flow using a resistance setting of medium-low, which that's the lowest resistance for any dry powder inhaler. Yet 70% still receive medications with a dry powder inhaler. So we started testing patients with this device, and basically it's the in-check dial, and it allows you to rotate and change the resistance level based on different inhalers. So there's like as you can see by the picture, the MDI Respimat, that's like no resistance basically. But then it starts to get smaller. The discus gets smaller, and your medium high, which is your handy inhaler, is the smaller. So that'd be like sucking into a coffee straw. And that would be difficult for pretty much anybody. So we basically, if a patient that we see on the outpatient side says they're on whatever type of inhaler, we're checking to see if, okay, they've been prescribed that, are they adequately meeting that peak inspiratory flow rate for that inhaler? If not, we're going back to the physicians and saying we need to change this to a different delivery device. I will mention, going back to what medications are on formulary, our only long-acting